Hearty good afternoon to all. Welcome to our last session. Today we are having a topic on end of life care. It will be taken by Tania. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. By 4, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Shiva's sister.
So good afternoon to all. Glad to introduce Sister TANIA CHALTON. She's a palliative care specialist nurse. She's working at Whitemeter District Health Board Hospital Palliative Care team. She has at New Zealand. She has 20 years of experience in palliative care. Today, she's dealing with end of life care. So this is our last session. This is one of the important session for the nurses. So, Tania, welcome over to you.
Thank you. So I'm going to be talking about end of life care or last days of life, and this is quite a short talk for something that's quite a very special and serious time in people's lives. So this is quite a, as I say, quite a short whistle-top tour. Thank you. So I think it's important to know what the definition of last days of life is to begin with. And in our culture in New Zealand, we say that the last days of life defines the period of time in which a person is dying. So it's the period in which death is imminent and may be measured in hours or days. It includes care during and around the time of death, but also immediately afterwards. And it includes management of pain, other symptoms, and provision of psychological, social, spiritual, and practical support for the families and caregivers. So the last days of life objectives really is to achieve a good death for any person who's dying, irrespective of the situation, the place that they're in, the diagnosis that they have, or the duration of their illness. We need to emphasize on the quality of their life and also the quality of their death. And we need to acknowledge that good end-of-life care is a human right, and every individual has a right to a good, peaceful and dignified death. So first things first is we need to actually recognise when someone might be dying. And this is usually where most of the problems arise, because it's not an easy thing to diagnose for some people. So can you tell me any signs that you would be looking for to see if someone was dying? What would you think a patient might show when they're dying? How would they behave?
Unconscious.
Yep.
Unconsciousness.
Yeah. Anything?
Unconsciousness.
Okay. Anything else?
Death rattles.
Yep.
Death rattles. Dilation of pupils.
Yep. So before then, what would you see if someone's starting to deteriorate? So before you get to your dilated pupils and your death rattle, what would you be looking for in somebody? Should we have a look? So someone becomes more weak, so they have a profound weakness. They have a reduced intake of food and fluids, so they start losing interest in eating and drinking, and they might have some difficulty swallowing their tablets. There's also, as you quite rightly said, they become drowsy or they get a reduced cognition, and they also may be getting confused and not recognising their family. Something else I've noticed as well is that patients will withdraw. So they don't always make contact with their families. They might actually feel like they're withdrawing from their families. And they will, as you said, lapse into unconsciousness. And that sometimes becomes more and more and more, so longer periods of unconsciousness. They're usually bedbound after progressive decline over sometimes days, but sometimes weeks. And sometimes you'll see peripheral shutdown. So they'll start to get cooler peripheries. And as you pointed out, when they become nearer to death, then you will start to get changes in respiratory rates. You might see periods when they're not breathing and then they breathe quite rapidly, and we call those chain-stoked breathing. Or you may call them periods of apnea, and they'll also sometimes change colour, so they become more paler, and you might notice cyanosed in fingers. So what we need to look at is when we're seeing people that are starting to deteriorate, we need to look and check that, is this deterioration acute, or is this an unexpected, or is this something that we would be expecting? Are there reversible causes of this deterioration? So are they hypercalcemic? Is it due to too many opioids? Have they got an infection, a sepsis? And if we think those things are present, we try to reverse what we can reverse, but also thinking about the fact that investigations or new interventions may not necessarily be appropriate or may be wanted by the patient or the family. So we need to be aware of these things, that even if we can reverse some things, it may not be quite appropriate to do so at that time. So we're planning our care now. So us nurses are going to plan care for our end-of-life patients. Make sure that we use good communication. Communication is very important in all care, irrespective of whether someone's dying or not. And we should be empathetic, compassionate, and effective with our communication towards patients and families. And we need to remember that this is the cornerstone of effective palliative care and end-of-life care, and that if we explain things properly and we communicate well with families and patients, that will relieve a lot of their anxieties and their worries at this particular time. Also remembering that listening is an equal important. You know, what are the patient and family telling you? What are they explaining to you? And we need to listen very carefully to what we're being told. And the ways of doing that is to maintain eye contact, providing a positive non-verbal feedback, such as maybe nodding your head, but not too much nodding. And because we don't want to look too like a nodding dog, so just a little bit of nodding would be sufficient. And also sometimes restating what you've heard, so saying, I hear what you said, you said such and such, is that correct? And hopefully you've got it right. And most important, not interrupting the speaker, which we sometimes do as healthcare professionals. We're so keen to help that we tend to interrupt sometimes. So what are your responsibilities? So your responsibilities as nurses is to assess and attend to the physical, psychological, social, spiritual and cultural aspects of all the patient's care. Provide measures for relief from any distressing symptoms, from pain, nausea and vomiting, shortness of breath, and as you call it, the death rattle, but I usually call it the respiratory secretions. I think death rattle sounds quite confronting, so I tend to call it respiratory secretions. Maintain a good relationship and effective communication, as we've already talked about. And that's in order to make sure that we're doing things as the patient and family would like us to, and not the way that we think it should be done. And to offer support to help the patient maintain some quality of life in the situation that they're in. We also need to prepare the best possible supportive environment, and that's usually around, if you're in a hospice, that's making sure that the families feel supportive and that we're attentive to their needs. Make sure that they end their life with dignity as well as comfort. And that's privacy as well, is making sure that we remain and make sure that they have dignity with regards to privacy. So if they're having a wash, we make sure that people can't walk in and out while they're having washes. And very important as a nurse to act as an advocate in communicating to and from the rest of the healthcare team. A lot of times when you're doing care, we spend as nurses more time with the patients than the doctors will. And so we may actually come across information that may be helpful towards the doctors to help with their care. And that's where we work as advocates. And it might even be as much as the patient says to you, I've had enough, I don't want to have all these medications anymore. And that's actually then advocating those wishes to the doctors so that they can deal with those things. Also respect the values held by the patient, taking into consideration any cultural, spiritual beliefs and customs that they may have, and making sure that they're able to deal to those. And offer support to the bereaved family to cope with the loss of a family member and a loved one. So that's not just when the patient is dying, that's once they've also died, that we provide support and care to that family whilst they're grieving. And there are a lot of challenges at end of life. There's difficulty, there's a difficulty recognising when a person's entering the dying phase, and you'll know that people, we're often saying, how long do we think somebody's got before they die? And it's the same with, we can't actually predict that. We can guess how long we think somebody may have, but it's very difficult to guess with any specific time, and we really shouldn't be giving anybody any time frames, because it can be quite detrimental, the time frame situation. And we've had lots of patients that have been told that they're going to die within a couple of days after having a stroke, and the family has been sitting and sitting and sitting, and the patient's gone on and on and on and on. So it causes a lot of distress if we do give specifics of when people are dying, but we can actually say it may be within the next week, couple of weeks, but certainly we're not talking months. But that's as specific as I would suggest if you're asked that question. Also, the process of withdrawal of treatment is very difficult, especially if we've started NG feeding or any of those indications. They're very difficult to stop at end of life once you've started. There's also a lot of ethical difficulties with regards to carrying on treatment, and also around family and patient decisions. Also, the relationship development with relatives. We try to have a good relationship with relatives, but sometimes we can maybe have difficult relationships, and it's working out whether our particular personality with that patient and family is not working, is trying to get another staff member to take over with us from that patient. Also, a lot of conflict amongst family members as well, when some family members will want one form of treatment, somebody else may want something else. So it's very difficult to, and again, really, really good communication. And also the problem with collusion, that the patient doesn't actually know that they're dying, but everybody else does. So that makes that very difficult to actually engage the patient in good end-of-life care if they're actually not knowing that they're actually ending their life. And a lot of times what I've certainly found is that patients, even if we haven't told them that they're dying, they do actually realise that they are actually entering end of life, but it's one of those things that they don't wish to actually articulate. So we need to confirm with the patient, family and caregivers that they're aware of that the patient is entering the dying phase. And I know this is very difficult, and sometimes they're family members that don't wish this to be portrayed to the family. So this is something that needs to be discussed with the family. We need to look at how we re-establish the goals of care. So when someone's coming towards end of life, instead of looking towards what chemotherapy they can have, what antibiotic we can give, we're then looking at rearranging those goals of care to making sure that we're doing exceptional symptom management. So we're making sure that they're very comfortable. So instead of going towards curative or prolonging life, we're actually looking at making sure that their life as it is now is as comfortable as they're able to have it. We need to discuss with the family and caregivers and patients the clinical plan of care, what we're intending to do. If we're stopping antibiotics, why we're stopping antibiotics. If we're stopping blood tests and observations, why we're doing those things. Also explaining to the family about giving different routes of medication. So if they're not able to swallow, we can give medication subcut. And also explaining about the continuous subcutaneous infusions that can be provided to keep the patient as comfortable as possible. For the doctor's part, it's good if they review the medications at this particular time, because we don't want to be giving the patient any unnecessary medications that they don't actually need and burden them with having to try and swallow medications. So stopping their, maybe their blood pressure medications, anything that's not really imminently required to keep them comfortable. And provide as much support and reassurance and education. And again, it's all around communication. So communicating what we're doing, communicating why we're suggesting things, why we're not doing things. And we'll talk a little bit about that a little bit further on with regards to nutrition and hydration. Is there anybody that this patient or the family feel that would be important to be with the patient at this time? We've just had a lady down in our inpatient unit, and it was in her last hours, and it was really important that her husband actually came. And that's another reason why it's really good to actually work out if someone is dying, because there are things and people that patients may want to see. There are things that they may want to do before they die. So this is why it's quite important. And we arranged for the husband to come in immediately, and he did, and she has subsequently passed away. So that's really important that we do these things. Making sure that we ask them any questions if there's anything particularly that's important to them at this time around spiritual, cultural beliefs that we need to make sure that we help to facilitate. And with regards to nutrition and hydration, that's a very emotive subject for a lot of families, and also a lot of physicians. And a lot of families feel that if we're not providing food or fluid at end of life, we're actually starving or dehydrating the person, and that's why they're actually dying. It's very important that they understand that dying is a natural process, and if we allowed people to die naturally, they would naturally not want any food or fluids. And as we talked about what are the signs of someone who is imminently dying or coming towards the end of their life, they actually are less interested in food and fluids. So it's the body's way of shutting down, and actually they don't require those food and fluids. So in point of fact, if we actually do give food and fluids at this time, we can cause more symptoms than we can less symptoms. So we're not actually, and this person's going to die anyway, regardless of whether we feed them or whether we give them fluids, because that's their natural process. Sometimes if we give fluids at end of life, you'll notice that people become more rattly. So you'll notice that what you call death rattle, what I call respiratory secretions. And that can sometimes be a side effect of giving extra fluids that the body's not able to cope with at this time. As well as sometimes you'll notice that at end of life, people start to become edematous in their hands and their feet. That's also around having excess fluid and a change in the albumin levels, which means your albumin becomes low, and any fluid that we're putting in then goes into the tissue. So we can cause more problems. But it is something that needs to be explained and discussed with the family at sometimes great length, because it does cause a lot of distress. Do I keep going? Yeah. So the overarching approach is the provision of care for people in their last days of life is the development of an individual plan. So it's always individual to that specific person that assesses physical, social, cultural and spiritual issues. The plan should be agreed, coordinated and delivered with compassion and take into account any wishes expressed by the family, the patient, and the plan should be documented clearly in their clinical notes and also undergo regular review, because people do change their minds and family do change their minds. So it's important to keep revisiting to make sure that things are still okay for them. It's also very important when you're looking after people who are at end of life, is that it can be quite rewarding, but it also can be quite draining and distressing sometimes. So you need to allow yourself some time out if the death's been particularly difficult. Maybe debrief with colleagues and do try and support each other if it's been particularly distressing for you. So when we're doing physical cares at end of life, are we all right? So we're talking about making sure that we'd be doing physical cares anyway for our patients, but it's making sure at this time that we specifically look at care at this specific time. So making sure that we've got the patient as comfortable as we possibly can. So making sure that they're supported, they've got pillows between their knees, they're on an air bed. carrying out hygiene cares and sheet changes daily or more often as we required, but do that at the same time that you're turning the patient, so you're not having to disturb the patient unnecessarily. If they're imminently dying, we would reduce the turns to sort of 4 hourly or maybe even less. If the patient's been quite distressed and it's taken a lot for us to get them quite comfortable, the last thing we then want to do is keep moving them every 2 hours to get them comfortable and disturb them again. But we do need to make sure that if they are restless, that we do change their position, because it may be that they're actually uncomfortable because they've been laying in that position for a while. Also, most important is ensuring that they get adequate pain relief given before and after pressure area cares. So if you notice when you move a patient that they're groaning, that they're frowning, that they look like they're uncomfortable when you are moving them, that you actually give them some pain relief about half an hour to an hour before you're going to move them, to cover that discomfort for them. And also to consider catheterizing someone at end of life, so that prevents skin breakdown, but also less moving for the patient and it's more comfortable for them. And most important is oral cares. Mouth care is the most important aspect of end-of-life care, and if it's not done adequately, if someone's mouth breathing, they can get a lot of coating in their mouth, which can be quite uncomfortable and may cause them distress. Families can be shown how to do the mouth cares, and I am sure that in your facility here we have little foam swabs or little swabs that you can use to gently put water or tea if they prefer tea, as long as it's not too wet, because we don't want them aspirating the fluid. And it's still our responsibility, even if the family are doing the mouth cares, it's still the nurse's responsibility to check the mouth to make sure it is clean and being well cared for. So we need to make sure that we're continuing to touch, care and talk with the patient even if they're unresponsive. Always assume that an unconscious person can hear you. It's most important that they think that we talk to patients, explain what we're doing every time we go near a patient. And the same with the family. It's good to explain to the family too that when they're actually moving a patient or going to do mouth care, is to explain what they're doing prior, because it's, you know, we don't want to shock the patient. So symptom management. Does anyone have anything they want to add before I go on to symptom management? Do you want to add anything? No. So symptom management, regular assessment of symptoms and any response to the medications, which is really important. So if you're giving a medication, it is really important to document if that's been effective or not. Because if, as nurses, you don't do that, when the doctor comes to look at the medication, look at the patient, look at the notes, he can't work out, or the nurse can't work out whether that medication's been effective or not, if you don't document. So if you say, I gave morphine for pain prior to moving, it was effective, then the next nurse knows that that's a good thing to do. If you don't put anything down, they don't know whether it's worked, whether it hasn't worked, whether we need to change things. So it's very important when you've given something for any symptom that you say whether it's been effective or not. Again, effective communication and listening, asking what their symptoms are, watching what their symptoms are, talking to the family, explaining why they have these symptoms, because it's, you know, there are a lot of symptoms that they can get at end of life, and it's explaining why this may be happening and that it's a normal process. Individualise the medications and non-pharmacological approaches, which we've said, set realistic goals, and the provision of any anticipatory medications. So we can anticipate that if somebody's had pain prior, they're going to have pain, they may well have pain at end of life. They won't necessarily develop pain at end of life, but if they've already had it, they may still have it now. So we need to make sure that we have that in place. Also that they may get respiratory secretion, so it's important to have medication charted for that, if they should get restless or agitated or distressed. So it's making sure we have those medications charted for us, so that if the symptoms do arise, you can act promptly and give medications in a prompt manner to keep them comfortable. And also making sure that if patients can't swallow and they've been on an antiemetic regularly or an anticonvulsant, or they've been taking benzodiazepines or steroids that are suddenly they're not going to be able to swallow, that we make alternative recommendations for those medications to keep them comfortable and stop withdrawal. So the main common symptoms that you may get in end of life is pain, delirium and restlessness, your respiratory secretions, dyspnea, and they may have nausea and vomiting. It's not usually a problem at end of life unless they've had an issue prior to their dying phase, or if they're dying from a bowel obstruction or some obstruction, that may well cause nausea and vomiting. So we need to make sure that we have antiemetics charted. So for pain, the non-pharmacological management, we need to consider the patient's total pain. So not only the physical pain, but the psychological, spiritual and social aspects of pain. So we need to take those into account as well. Positioning, so position the patient as you think they may be comfortable, have pressure relieving mattresses. Sometimes distraction can help, so sometimes having music if they like music, talking with them about reminiscing. Sometimes heat or cold packs, massage can help, and sometimes just having somebody here to say prayers can help reducing pain and existential suffering. So the pharmacological management, we need to watch for non-verbal cues for pain. So your patient may not necessarily tell you that they've got pain, but if you're watching the patient, you should be able to notice whether they're in pain. So if they're groaning, if they're frowning, if they're a bit restless, may all indicate that the patient may be in pain. Continue to use the paracetamol if you can, and sometimes it can be given PR if needed. I don't necessarily use PR paracetamol, but I know that some centres do like to give it if it's unable to be swallowed. If they're on an oral opioid, we need to convert that route to subcutaneous, and we may even need to actually consider using a subcutaneous infusion or a CSCI. Especially if you're needing to give medication every 4 hours, subcut, it would be better to put that medication into a syringe driver and allow a steady flow of pain relief. If the patient's renally impaired, or if they've already been on methadone, it might be that, do you have methadone injection? No. Tablet. So you would need to use fentanyl subcut in an infusion if you had if they had renal failure. Currently, methadone is not available as an injection, so we wouldn't be able to use that. So, So delirium and restlessness, about 68 to 88% of patients are delirious just before death. So it's really quite important to know that that's one of the very common symptoms. It can, if it's reversible, if it's irreversible, I should say, it may be an indication of impending death. Can be very distressing for families when the patient's confused and doesn't recognise them. And it's important to involve the family, explanation and reassurance and support, and explain why this is actually a normal part of the dying process. So your reversible causes, it can be pain related if they're restless and agitated. Could be that they're in urinary retention, so it may be that putting a catheter in might relieve their agitation. They might be fecal loaded, but it is important to also look at the patient and how soon they are to imminently dying as to whether you would provide any fecal, any enemas or anything at end of life. If they're imminently dying, I would not do enemas at that time. Are they hypoxic? Do they need a little bit of oxygen? Are they opioid toxic? And consider existential distress. So psychological discomfort, anger, guilt, fear, any unfinished business that they may have had. For delirium and restlessness, the cause is often multifactorial. Readily treatable causes should be excluded. So if pain, urinary retention, but many causes are not reversible, and the burden of the investigations in a dying patient is often best avoided. We need to make sure that we have a calm environment, quiet environment, and subdued lighting if we possibly can, familiar voices, a safe environment. Here you don't have low beds, but you've got bed rails. In New Zealand, we have beds that go right down to the floor. So if someone's really restless, then the bed's near to the floor, so it's much easier. But you have adequate supervision with families being there 24 hours or a carer being there 24 hours so they can observe the patient. Minimise the amount of strangers going in and out is quite important because that can agitate people, and suggest spiritual and religious guidance if appropriate. So for first line in the management of delirium, we would use haloperidol regularly at night, and if they can take it orally, but most often subcut, and can also chart haloperidol SOS. And with haloperidol, you can give it once a day because it's got a long half-life, so it actually lasts over a fair period of time. You can give it twice a day if need be, or more often. Don't use in Parkinson's disease or similar disorders because it can make the Parkinson's worse, so it'll make people stiff, and that can cause distress. Can also be helpful for the use of nausea and vomiting, so it can be used for two things, which makes it quite a good drug to use at end of life because it can use two purposes. Second line, in a conscious person, or if they're unconscious, you can use first line, is midazolam subcut also. And I think you use a lot lower doses than we do. So I think your doses to start are 0.5. For midazolam, our first dose would be 2.5. And also for haloperidol, we'd use 1 milligram at night, but I know you guys use a lot less, which is 0.5. And generally speaking, we wouldn't use any more than 5 milligrams in total in a 24-hour period. So your respiratory secretions or your death rattle, some patients are more prone to getting respiratory secretions. So patients that have lung cancer, gastric cancer, if they've got an existing pneumonia or a chest infection, but sometimes it can be really hard to predict who's going to develop respiratory secretions. It's often a most distressing symptom for family and staff, because we have a limited capacity to help with the management of it. And families often feel quite distressed because it sounds like they feel that the patient's drowning. So once again, staff and family education is really important. So explaining to the patient and the family, because the patient will be unresponsive at this point, is that there is very little fluid that's usually in the lungs that's making this noise. So it's a bit like if you've got a drink and you've got a straw and you have a little bit of the drink left and you suck up that tiny little fluid with your straw, it makes a huge noise. And this is what's happening in the respiratory tracts, is that it's a small amount of fluid, but it's rattling around in the airways, and so it makes a lot of noise and it sounds worse than it actually is. Usually, patients aren't particularly distressed by the respiratory secretions, and it's again, education to the family is really important, and reassurance to them as well. Early assessment of risk is helpful, and to treat earlier rather than later. So if you hear any respiratory secretions, is to give them any medication first, not wait till it gets too bad, because the medication that we give, which is buscopan or hyoscine butyl bromide, it helps stop any secretions being developed, but it won't get rid of secretions that are already there. So it's important that it's used earlier in the piece rather than later. However, there has been a systematic review that has showed no evidence that using an anticholinergic, which is hyoscine butyl bromide, for end-of-life secretions is any more beneficial than non-pharmacological interventions. So that's something else to think as well, that if you're giving the buscopan, it's not working, it's probably no benefit from keep giving it. So maybe just as effective as medication is a change of position. So changing the patient onto a different side, sometimes just raising the head of the bed a little bit, reviewing the appropriateness of continuing with any IV or subcut fluids that you might have going. Regular mouth and lip cares are very important. We don't generally use suctioning For patients that have got secretions, you can, if you want to, just get any secretions that are in the mouth. Just remove any secretions that you can see, but don't do deep suctioning because that can be very distressing for the patient and for the family. Any questions so far?
Any questions?
It's quite a lot of information in a short period of time.
Vilasati? Sister Ramalakshmi? Rajeshwari, Vijayalakshmi and all. Any questions so far? Any doubts?
No? Okay. Oh, no.
Yeah, tell me.
Sister Vijayalakshmi, you had any doubt?
Okay. So dyspnea, reassurance to the person and their family, most important. I think what you're probably getting as we go through here is the education of the family and the communication with the family with all of these symptoms is really important. So positioning of the patient. So if they're unconscious, they may need to be sat upright and well supported by pillows to try and help with the tension in their shoulders. Environment, provide a light, airy room if we can. Having the fan going is really good, and sometimes an electric fan onto someone's face can help. Sometimes a damp cloth because it will activate the fifth cranial nerve, which will help with the breathing. And sometimes a fine mist spray can also help. And trying to talk in a relaxed, calming voice can sometimes help, and trying to slow someone's breathing down if they're still conscious. Usually we use morphine for dyspnea as first line. It's still the gold standard. If they're dyspneic and anxious, you can add in some lorazepam or a benzodiazepine at night if they're able to swallow, or sometimes we'll use some midazolam. But midazolam is only helpful in dyspnea if somebody is really anxious around their shortness of breath. What we've had in New Zealand is that a lot of doctors have been using midazolam on its own without the morphine, and all that really does is make somebody sedated. It doesn't do anything for their shortness of breath. Whereas the morphine, although we're not sure of the exact action of why it helps with shortness of breath, it does help to slow and settle the person and help with their actual overall feeling of shortness of breath. So although midazolam does have a role, or a benzodiazepine does have a role, it's important that it's used in conjunction with the morphine and not solely on its own. Oxygen, we don't tend to use much oxygen at end of life. The only time that we may use oxygen if someone's severely hypoxic, we may use some oxygen. But what we found and what the patients' families have said to us is that they find the oxygen and any extra tubings and things that we may have on patients at end of life form a barrier to them to be able to actually be with that person. So we're trying to avoid those barriers as much as possible, but making sure that the patient is as comfortable and symptomatically managed. So with your ongoing assessments, it's important to document your ongoing assessment. So you'll be assessing your end-of-life patient every 1 to 2 hours. Do they have any pain, restlessness or agitation? Do they have any dyspnea? Are they developing respiratory secretions? What we've noticed in some of our hospitals, and I'm sure you guys don't do that, is that when someone is end of life, they are almost put into a room and then the family are with them, and then our nurses don't go in to actually review them. And so it's really important, and we have to do a lot of education with our nurses to actually make sure that this isn't a time when you need less care. This is a time when the patient needs more care from you. And we need to make sure, once again, that we've written down what interventions we've given and if they've been effective. So when we're commencing a subcutaneous infusion, we may do this at end of life, and we may do this if patients are unable to swallow their medication. So if they're on an anticonvulsant normally, or benzodiazepines, if they're normally on morphine and they can't swallow, we need to make sure that we do a driver for that. Also, if someone's having seizures, if we can give anti-seizure medication via the pump. What we tend to use for anti-seizures is midazolam. And also when you're requiring increasing doses of an SOS, so if you're having higher and higher and higher doses of medications, you might need to actually put this in a syringe driver. And it provides better symptom control by reducing the peaks and troughs of medication effect. So if you, pain-free is here, and if you give a medication, they've got pain, you give the medication, it comes down to pain-free, and then you'll get a dip, and then they'll be up and down. Whereas if you're giving continuous medication, hopefully you're keeping them at a level that's acceptable to them. So we need to remember that as nurses, we're in a unique position to help guide patients and families through this transition from life into death. We only get this one opportunity for this patient to do it right, so it's really important that we do get it right. And we need to remember that when we do also do end-of-life care for a patient, that it impacts on the family that are there. If we do it badly, they'll remember that we've done it badly, and the next time that they have a patient that's dying, they will be more distressed and more anxious than they would have been if the death had gone well. So, any questions?
Thank you, Tania, for the detailed presentation on end-of-life care. So, anybody would like to ask any questions, please ask.
I know it's quite a lot to take in.
During the end-of-life care, the nurses are more time spent with the patients. So, I think nurses has more doubts. So, please ask any questions. Dilasa team.
व्हिडिओ स्टार्ट कर.
Any questions?
How to document that end of life patient documentation?
Okay, document end of life care, end of life patient.
Well, I think that's quite a big question, because when you're documenting your end of life, so the doctor has decided that this patient is end of life, okay, and you nurses have decided this patient's end of life, so it should be a multi-team decision. So then when you've decided that, in your notes, you will be writing down this patient is entering end of life, currently unresponsive. I'm just using this as an example. Appears to be in pain at turning, given pain relief prior to turns, and so it's, rather than doing a bullet point, it's more of a story about that patient, how they're managing, how things are going. So we're not interested, so you shouldn't really be too interested in the numbers. So I wouldn't be interested in what their blood pressure is. I wouldn't be interested in what their temperature is. But what I'm interested in is how comfortable they are. Do they look comfortable? Are they responsive? Are they short of breath? Are the family doing okay? Is there any extra anxieties from the family? And this should be how you would document in your notes. So rather than documenting bullet points, it would be more of a story for the patient. So patient unresponsive, patient appears comfortable today, families settled, no concerns from the family. Those sorts of things are what you should be documenting, rather than any pain, any blood pressure or temperature or any of those things. So it's slightly different to the documentation that you would do normally, because I know it's quite bullet point, isn't it, the documentation? Yeah, because this end of life documentation won't fit into your care plan, I suspect, that you do normally on an everyday basis. So you need to actually formulate your own plan for this patient. And what I will do is I've got a care plan that shows you how to document, and I will share it with Shiva, and she can forward it to you so that you can see how we would document. Does that help?
Yeah. Yes. Thank you. Thank you.
No worries.
Thank you, Sister Tanuja. Anyone else is having a question or your experience with a patient? Yes, Sister Ramalakshmi. Ma'am, we can't hear you. Can you unmute and speak?
Madam, in end of life care, provide the psychological and spiritual needs for the end of the patients. How we can provide it, madam?
How can we
Spiritual needs.
So how I would do it with my patients is I would actually find out what religion they are. Are they Hindu? Are they Christian? Are they Buddhist? I don't know if you're Buddhist yet. What religion are they? And what does that entail? What does that mean for them? Because even if you're a Catholic, do you go to church? Do they want to see a priest? If they're Hindu, what does that mean to them? Do they need any specific help with practicing Hindu? Do they need to see somebody to talk to? So it's actually exploring what their religion is, what their spirituality is, and what it means to them. And sometimes spirituality is not about religion. It might be about what's important to them. So we had a patient that what was really important to him is that he made it down to the beach. So we actually took him we carried him down so that he could see the beach, and that was what was spiritually important to him. So it's exploring what is important to that person and that family at this specific time, and trying to do that for them as best we can. And we might not always be able to do it, but it's trying to, so the family can see that we are trying to do it. And it may be that they want to be at home, at a specific home, and that may be out somewhere where it's far for them to go, but it's trying to facilitate what is important to that person and that family at this specific time, whether that be religious or spiritual. And it's all around, again, I can't say it enough, it's all around communication. And communication with the patient before they become unresponsive, which is why advanced care planning is so important. Because if you talk to a person when they're diagnosed about what's important to them, then when they become towards end of life, you will be able to actually help. The family will have talked to the patient around what their advanced care plan is, so you'd be aware of what's important to the family and patient at that time. And I know that that's becoming more important in India as well, having an advanced care plan so you can plan what's important to you. All right? Thanks. That's it.
Thank you, Sister Ramalakshmi. Any more questions? Yes, Sister Kavita.
Ma'am, we had one patient with CA oral mucosa. So at home, she was literally kept separated, and she has developed one opening here, and inside there so many maggots, fistula.
Oh dear.
So then she was brought here in very bad conditions. So every day we were removing maggots more than 300. So in that case, and that patient's family members were very reluctant to touch her and all. So how to meaning to
End of
console
life
the
care
end
of
of life care to teach patients and patients' family members.
So so is she conscious? Is she still
She
conscious?
was
Or?
conscious in the first 2 days, then later she became unconscious.
Right. So I think if the family, all you can do at this time is actually talk to the family and try and encourage them. If they really don't want to do anything to the patient with regards to mouth care or looking after that wound or anything like that, then we as nurses need to step in, and this is where we as nurses need to do her care. So we need to actually make sure that we're doing mouth cares regularly, and we're changing the dressings, and we're doing any of the changes that she needs. So basically, we as nurses take over from the family if that's what they wish, because at the end of the day, we can't force family to look after somebody. We need to actually have to do it ourselves. You can just talk to them and encourage them and say, I'm going to do the mouth cares now, do you want to watch me? And get them to watch you doing it, and gradually they may get more comfortable with doing mouth cares and things like that. What is it they don't like? Is it because of the maggots that they saw, or is it, yeah?
Because
So
of maggots continuously over the 24 hours they were coming from mouth. So
Yeah.
they have to be ready with artery foci, with mask, and also they were.
Yeah, and all those maggots have gone now.
She expired.
She ex-
Expired in our hospital.
Oh, that's a shame. That's
So
a
it
shame.
was everything was that it was gone with that.
was
maggots.
eaten by maggots.
Everything, even notes we can actually see from this to that entire cavity, oral cavity.
Dear. Oh dear. And is someone going to follow up with the family after? You know, now that the patient's expired, do you?
Not yet done.
Does anybody follow up with the family?
No.
No, we are on planning.
We are planning to do.
Planning, yes, because I suspect with something like that, that is quite distressing for them, I would imagine. Distressing for the patient, but distressing for the family to see that happening would be something that they probably won't ever forget. That would be
Because
quite.
at home they had kids and all, that's why they had kept her separated.
Yeah.
In separate room. And she was very dirty.
Was she? Oh dear. Oh dear. I'm sorry that she had to go through that, and you did too. How did you feel about that? How did it make you feel?
We can actually see her pain. That
Yeah. Was that distressing for you?
Yes.
Yeah. And do you have anybody that you can talk to when you've seen something like that? Do you have somebody that can help you talk through? No. No. Okay. Do you want to add anything?
Usually that regarding the fungating ulcer, if the patients develop fungating ulcer in the family, usually they choose a corner side of room. So maybe because of their fear and anxiety of spreading of the disease. You just find out whether so individual conversation is very, very important for this type of patients. So when they come to you, you just need to talk to them individually. Patient conversation and family conversation. Sometimes within the relatives with the patients won't tell anything. So you need to talk to them individually whether they are actually supporting or not. Otherwise, they always say, okay, he or she is supporting very much, something like that. So you just do the individual conversation. There is some entirely different. So maybe here also they choose the separate room because of maybe because of this fear and anxiety inside.
Could have been smell.
Yeah, the foul smell is also there, So that is distressing to the family members. So we try to reduce the smell. So how will you reduce the smell? This type of wounds, maybe fungating ulcers is one of the main problem is foul smell. So how will you reduce this smell?
Sister Kavita, we can't hear you. Can you unmute and speak? Yes.
Dressing with Metrogel. Everyday dressing with Metrogel. Frequent mouthwash, mouth care.
Okay, it's good. It's it's important is cleaning with normal saline first and metronidazole. This is an anaerobic bacterial infection. So this is because of the hypoxic devitalized necrotic tissues in the wound. So that's because of that producing smell. So the one of the common antibiotic is good antibiotic is metronidazole. So the patients having oral cavity fungating ulcer, so CA buccal mucosa, you can irrigate with injection metronidazole. Okay, so injection metronidazole, same injection metronidazole you can take with the help of syringe. You can instill some amount that will goes inside and reduce the smell. Okay, and charcoal. Charcoal dressing also. Charcoal dressing is available, but the problem is too expensive. But charcoal pieces are the charcoal piece so easily available. So okay, you can take 1 or 2 pieces into the corner of the room or under the bed. That will absorb the bad smell. Even coffee vinegar, that bowl of vinegar, coffee, and vanilla, that also absorb the bad smell, that will produce the good smell. And honey, sugar dressing is also that literature says. We don't have any experience on this, but we usually give metronidazole dressing. That will reduce the anaerobic bacterial infection. Okay, thank you.
Thank you, sisters. Anyone else with a question? I think we can move on to case presentation then. It will be taken by Sister Ramalakshmi. Over to you, sister.
Yes, madam. Good evening, all. My name is the Ramalakshmi. I am working as a staff nurse in Mahatma Gandhi Cancer Hospital.
Sister, can
Case
you,
presentation details are.
sister, can you move your microphone?
Hello.
Can you move your microphone closer to your mouth and speak loudly?
Okay, madam.
Microphone.
Good evening to all.
Yes, yes.
Now, okay, madam.
Okay, madam.
Today, my case presentation details are followed by the patient name is C. Srinivas, 37 years, male patient, diagnosis AML FLT3, positive with a normal karyotype. Presenting complaints are suffering with fever since 3 days, weakness, body pain, decreased intake. She is a known case of AML post BMT since June 2019. History of the illness. Past history is he was presented with complaints of fever since 15 days, admitted in local hospital, then referred to the Tata Memorial Hospital in Visakhapatnam, where he has evaluated for his symptoms and diagnosed with AML FLT3 positive with normal karyotype, then referred to the Indo-American Hospital in Hyderabad. He undergone CR1, follow in Indo-American Hospital. Later 2 cycles of high dose ARSE taken. Matched sibling allogenic stem cell transplantation. Day plus 21 after the course, he was discharged. Discharge advice, follow-ups, diet recommendations, strict neutropenic care has explained. Present illness till 28th January, he was healthy, but suddenly the patient got fever since 3 days and weakness, body pains and decreased intake. Now he was admitted in Mahatma Gandhi Cancer Hospital for medical management. Physical examination, vitals are not stable. He is febrile and he is having continuous temperature. Patient complaints every body pain score 8 by 10. General weakness, complaint of the vomiting, sleeplessness, nausea and vomiting. Investigations are CBC, LFT, serum creatinine, blood for culture and sensitivity, chest X-ray for PAB. Other routine blood investigations was done. Psychosocial aspects are he was married and have a one son and daughter. He is working as a teacher, so he want to get discharged early and so he can carry out his teaching at school. He always support to the students. His wife also well educated and well cooperative for his treatment. He have small family and family members knows about his disease and prognosis. Main concerns are the patient concerns are he want to be good health, fast recovery from suffering. He wants to go to home. He wants to teach to the students. Family concerns are patient comfort. He wants to go home. Treatment are medications are injection ciprofloxacin 2 gram IV BD, injection paracetamol 1 gram IV 6 hourly, injection ondansetron 8 mg IV SOS, cap cyclosporin 150 mg per oral BD, cap 4 can 200 milligram per oral OD, cap ACVR 400 mg per oral TID, cap Livobact 500 mg per oral OD, tab Udiliv 300 mg per oral BD, tab folic acid 500 milligram per oral OD, tab Deprion DS per oral BD, tab MSET 8 mg per oral BD, IV fluids DNS and NS 100 ml per hour, encourage oral feeds, follow anti-infective measures, keep sponging. Summary. Mr. T. Srinivas, 37 years, male, was diagnosed with AML FLT3 positive in February 2019. Had indication in 7+3 in March 2019. In CR1 was consulted about need for allograft. Then HLA typing with siblings, sent and in meantime had 2 cycles of HADAC. In meantime, HLA typing with his siblings shows his brother has fully matched after discussing about complications and benefits in details in deal with his family. He was admitted for transplantation after cardiac and pulmonology clearance. After transplantation, he was managed and discharged with advised of follow-ups, diet recommendations, strict neutropenic care. In between follow-ups, he was suffering with fever, weakness, body pains, and disgust and decreased intake. He was admitted on He was admitted in Mahatma Gandhi Cancer Hospital for medical management. Discussion points are what we can do this patient, how to protect this patient, what we can educate this patient. Thank you for all.
Thank you, Lakshmi, for the presentation. So anybody would like to ask any questions, any clarification regarding this patient story? So please ask to Ramalakshmi sister.
Sister, can you tell, is this end of life care
Related case.
related case?
So Ramalakshmi?
Actually, madam,
Yeah.
actually before only I prepared this case presentation, but at that time I didn't get this chance. Now only the madam told to the presented today case presentation. That's why I have. I didn't prepare new related to the end of life case presentation. Only I did the only general case only.
Thank you, Sister Ramalakshmi. Sister Tanuja, this is one of the not a end of life care patient. So we will discuss. No, we know palliative care should start from the point of diagnosis. So we need to discuss these patients. Anyway, these patients one day go to end of life care. So we need to manage this patient. So we need to discuss today itself. Okay. Okay, the first question, what we can do for these patients? You tell me, this is our last session. We learned most of the topics. So pain, how will we manage pain and how manage restlessness, respiratory problems and or delirium and all. So you tell me, how will we manage, what we can do for this patient? Sister Anisha, are you there?
Yes, ma'am.
Yeah. Tell me what we can do for this patient. What are the side effects of chemotherapy?
Madam, vomitings, diarrhea. Hello?
Yeah, tell me.
Vomitings, diarrhea, ma'am.
Then,
General weakness,
okay,
sometimes complaint of fever,
okay,
headache.
okay,
Most commonly diarrhea, madam.
okay. Any other problem? Any other symptoms?
Loss of appetite,
Loss of appetite?
hair loss,
Okay.
mouth sore, mucositis, madam. Mucositis.
Mucositis. So,
Most commonly used, mucositis.
yeah. Then how will we manage?
Skin and nail problems, madam. And means discoloration in the skin and nail.
Okay. How will we manage their nausea and vomiting?
Means
What medications did he have charted? So if we're going to manage his nausea and vomiting, what would you give for nausea and vomiting?
Medications, ma'am.
Is what medication you suggest the patient is on chemotherapy?
Ondansetron.
Yeah. So if he's not eating and drinking very much, it's giving him small meals, something that he fancies, making sure that he's given an antiemetic before a meal so that he may well feel like he wants to eat, making sure that he doesn't become dehydrated, good mouth cares to prevent and help if he does get mucositis. What else do you think you should be doing for him? What were his symptoms? So he had nausea and vomiting, he had sleeplessness, he had pain. So it's making sure that if we go back to, I know he's not end of life, but if you go back to the principles of end of life care, it's making sure that he's got all the medications charted that he may require. So if he develops pain, if he develops nausea and vomiting, that they're all charted for him to be able to have when he needs them. It's to make sure that he's in a cool room, because if you're really, really hot, you can feel nauseated. So make sure he's in a cool room, cold flannels. You're also going to be needing to make sure that he is likely to be neutropenic. So we need to make sure that he's in an environment where he's not going to come into contact with a lot of people that are going to give him an infection. So I would suggest that probably you wear masks if you're going in, so that you reduce the risk of giving him any infections. And also he's feeling weak, so he's going to need help with cares. We need to make sure that his pressure areas are okay. Even though he's young, we still need to make sure he's quite unwell at the moment, so we need to make sure that his pressure areas are okay, that he's being able to look after himself. What do his family feel is going on? What does he think is happening? Is there anything that's particularly worrying him at this time? Anything else you can think of? He's not very old, and he's a teacher, and I suspect he's feeling quite frustrated at not being well, and he's worried about his students, I think we read there. So there's going to be a lot of psychosocial issues that may be a problem for him that need to be discussed, and that will impact on his physical symptoms as well. And we need to have a plan of care as well for him. If he's going home, how does he keep well at home? We need to make sure that he knows what needs to be done, how to reduce his infection risk, which comes around to what we can educate the patient. So what else do you think we need to do for this patient?
Okay, Tanya, if suppose this patient comes to you with delirium, how will you manage? How will you assess? What are the things you are going to assess? If this patient comes to you with the complaints of delirium, what things you assess and how will you manage? We already discussed delirium management, non-pharmacological and pharmacological management, but we nurses, when a patient comes to you, we need to assess. We need to identify the cause of the delirium. So what are the things you going to assess?
what medications the patient is receiving. If he is
Okay.
having any constipation.
Okay.
Then if patient is talking any irrelevance, any involuntary movements.
Okay. Then.
Personal history like alcoholic, smoker,
Okay.
or using any medications.
Okay. Then. Sister Rajeshri. Sister Vijayalakshmi. What are the causes of delirium?
Hello, madam.
Yeah, what are the causes of delirium?
Ma'am, taking history up about pain relief medications like morphine and other medications causes delirium.
Okay.
Any electrolyte imbalance.
Any electrolyte imbalance.
Very, very important is electrolyte imbalance. These patients maybe might be developed mucositis. Maybe he's not taking orally because of that mucositis. Pain is another cause. So dehydration is one of the main cause for these patients might develop delirium. So electrolyte imbalance is important. Dehydration is one of the cause, and pain, urinary retention, constipation. There are a lot of causes. So you have to identify the cause of delirium. Okay, infection. So these patients after chemotherapy anyway reduce the immunity power. So these patients might develop get infection from the infected person. So when you that post chemotherapy patients, you instruct the patients not allow too much relatives when they are sick, especially head and the throat, mouth and throat infection there. So they are getting that infection easily. So you just instruct the patient caregivers about this. So anything else you want to discuss? If the patient is on morphine, so when the patients come to you, the oral morphine, after that the patient is unconscious. So do you reduce the dose of morphine or do you stop the morphine? What will you do? If a patient comes to you with oral morphine, 10 milligram orally, after 2 days, the patients go to end of life care. That means not taking anything orally. So how will you manage his pain? Do you reduce the dose of morphine or what options you choose?
Morphine infusion.
Subcutaneous infusion.
Same dose?
No, reduced
No.
dose.
Reduced dose. Why?
Because patient is drowsy. End of life.
Patient is in end of life care. Do you reduce the morphine?
Based on patient's drowsiness is there.
No drowsiness, no drowsiness. Only patient is unconscious. No drowsiness present. Our
Madam?
scientists, we need to overcome this situation. So we need to discuss this end of life. Sister Rajeshwari, you have...
Madam, patient already unconscious, ma'am.
Yes.
We will stop morphine, ma'am.
Okay. Then anything else? Any answers? Sister Anusha.
We'll stop morphine, madam.
Stop morphine. Sister Ramalishmi.
If patient is unconscious, if we continue morphine means the patient will go into deep unconscious, madam. So the stop the morphine is the better.
Okay. Sister Vijayarashmi. So very, very important in end of life care, we can continue the morphine. Okay, same dose. But the thing is, the route is when the oral route is inappropriate, you can choose a rectal route. Okay, we already learned rectal route is another option. So rectal, you can same dose, you can take same medications, make it a paste, and then you can put in the rectal mucosa. Okay, rub it on the rectal mucosa. That okay, you can choose a rectal method where you can administer rectally. Then the another option is continuous subcutaneous infusion. Okay, so if unconscious patient there, better you can go subcutaneous infusion. But how will you give convert the morphine, oral morphine to subcutaneous? Last time we discussed. Suppose the patient is on 10 milligram morphine 4 hourly. What is the total dose that patient is getting one day? 10 milligram 4 hourly.
60, ma'am.
60 milligram. Then how will you convert from oral to subcutaneous?
60 milligram. 60 mg over 24 hours. That morphine dose subcutaneous injection.
Okay, over 24 hours, the patient is getting 60 milligram oral morphine. Okay, so how will you convert from oral morphine to subcutaneous?
That injection will be diluted in
injection, yeah. Half dose, you can give half. Okay, take 30 milligram over 24 hours. Okay. So you can continue the pain medication. So if the drowsiness there, so if you can just how will you ask that? How will we know whether the patient is having pain? For example, an unconscious patient. When you turn the position, as already discussed the importance of turning the position, Tania. So when we turn the position, usually the facial expression will be different. Okay, so we are so here we need to know when you turn the position. That is maybe you can increase the frequency. You can increase, and you that too early changing your position is very, very important. But maybe you can increase the frequency 3 hour early or 4 hour early. You can induce that time. You can give the injection also. Okay, so otherwise that in between that that if you give on one time you can go for an injection. Anyway, you can tell the patients whether the patient is unconscious or semi-conscious. That is not a problem, but you can tell the patient what you are going to do. Okay, you explain the patients about the procedures and all. So every time we just that discussing the patient. So when you turn the position, if you need to change the position, that time you can give the medication also. And and regarding the respiratory secretions, we usually the caregivers come to you give a IV fluid. Okay, the patient is not able to take orally. Can you give a pint of fluid? Or usually caregivers request you like that. So how will you respond? How will you respond this question? My mom is not taking orally. So can you give a 1 pint of fluid? That request come. How will you respond?
We encourage the oral feeds, madam.
You explain the oral feeds is it is difficult. So you just here you just need to explain the caregivers about the respiratory secretions. If you respect the, we need to respect the caregivers' concern also. But even then, you when what if they maybe if their mind may be different. If we give fluid, okay, the patients will they might feel okay, the patients feel much better if you give 1 pint of fluid. But the other than that, if we give if we respect the caregiver's concern and give 1 pint of fluid, that will distress to the patients, that will increase the respiratory secretions or death rattle also. So we need to listen the patients, the relatives concerned first, and then we can explain to the caregivers, the relatives about the side effects of feeding or feeding. So this is and the end of life care is very challenging on this nutrition and hydration.
What you can do sometimes with hydration is, if there's a real anxiety from the family's point of view about having fluids, you can explain to them that we'll give subcut fluids. However, if the respiratory secretions develop, we will then have to review and we'll have to stop the fluids. So it's actually explaining that if yes, we can do this, but if the respiratory secretions do develop, then we will have to review and we will have to probably stop, because it will be causing the patient distress, or can cause the patient distress.
And one more thing, if death rattle present, you should not do any suctioning. If you do the suctioning, that will stimulate the that mucus again. Again that secretion will increase. So you can do the mouth care and positioning, side lying position you can give. That's it. Any last questions? Have any last questions?
If we give IV fluids, IV or any subcute fluids in end of life care, but how there is this increase of secretions? How it can help?
It's to do with the because when you're dying, your albumin gets quite very low. It's an indicator of a poor prognosis. So the lower your albumin is, so when you give fluid, then the albumin. So then the fluid, instead of going into the tissues, into the veins and going through, it gets drawn out into the fluid, into your tissues.
Yeah, that yes. If you introduce fluid through subcutaneous,
yeah.
So how that subcutaneous fluid acts? That diffusion and perfusion method, no? That will goes to the blood circulation and go to our that system. Okay. So if you increase the or with that circulation is end of life care, what happened? The circulation is ready down. Okay. So if you introduce much fluid through the subcutaneous, what happened? The patient is not able to breathe normally because of might be develop pleural effusion. Okay, so because of that fluid overload. Okay, all fluid will come through collect through respiration, bronchus, something like that. So that orally, especially gastric secretions also increase. Okay, then the patients develop nausea, vomiting. So that's why we reduce the fluids in end of life care. If the that secretion increase, you can give glycopyrrolate subcutaneously, or even if gastrointestinal secretions increase, you can go for hyosin butyl bromide. Okay, that will decrease the gastrointestinal secretions. Okay, thank you. Thank you all. Thank you, Tania, for the wonderful presentation. Thank you, Sister Ramalashmi, for the patient story presentation. Okay, thank you.
Thank you, ma'am.
I've shared the feedback link. So we are coming to the end of our 17 sessions, which we started right back in October. So thank you all for being patiently with us. We started with a group of 14 nurses and we could complete with around 10 nurses. That makes a very good attendance throughout. So thank you all for joining in. So before we leave off, I wish to hear from all about how relevant our program was to you. Like mainly the critical part of it, so that we can improve our program ourselves. So anybody wishes to give a passing comment before logging off?
Yeah, this is our first nursing echo program. So
each and every inputs from your side, it's a teaching factor for us.
Any comments or feedback, any suggestions?
Yes, Sister Ramalakshmi.
Thank you for your team, madam. Every section we learn so much. So, and every section we learn new